Good morning. My name is Sarah Strandberg. I'm a speech language pathologist here at Stanford Healthcare in the Department of Outpatient Rehabilitation. And we've been able to see patients with long COVID since the early summer of 2020, before this was really recognized as a clinical entity. And so I'll be speaking today specifically on our role as speech pathologists with patients with cognitive impairment. And these are the patients, as we've heard previously today, that are coming into clinic and reporting that they have brain fog. And more specifically, they're reporting impairments in concentration, memory with increased forgetfulness, difficulties with word finding, problem solving, reasoning, and overall difficulties with many daily life activities, including compromised performance at work and school, if applicable. As was mentioned previously, there's lots of number data coming out from different studies, but a paper in 2022 found that about 22% of individuals with long COVID report cognitive impairment. And what was really interesting and striking to learn as the first few years of the pandemic passed was that we can see cognitive impairment across the spectrum of COVID infection severity. So this is not something that occurs only in individuals who were hospitalized or critically ill with their COVID infection, but we see cognitive impairment in the context of long COVID following a very mild COVID infection, and even in patients or individuals who are asymptomatic at the time of their COVID infection and simply had a positive test. Again, the mechanism of cognitive impairment in long COVID is not clearly understood, but many studies are looking further into this. And I think Dr. Presswood's review of this during his talk a few moments ago was excellent. And so what we do know is that the cognitive complaints occur in the context of many other symptoms that we've also heard about today, such as fatigue, anxiety, depression, and multiple physical symptoms. But what is striking are the similarities to other patient populations that we have many more years of experience with. And specifically in terms of cognition, we can draw quite a bit of similarity to our post-concussion patients, as well as chronic fatigue syndrome patients, where there is a significant symptom overlap between cognitive and somatic domains.
Sarah, sorry to interrupt. Do you mind putting it in presenter mode?
Yes, I
Thank
just
you.
realized that that was not happening. Sorry
Thanks.
about that. Um, And again, as we've learned today and in our previous seminar, long COVID is a complex multi-system condition. And while many individuals can access care at long COVID clinics, it is possible to receive this same care outside of the context of long COVID clinics, as long as the appropriate referrals are being placed to these providers. And there's ongoing emerging research and evidence on the characteristics, etiology, and care of these patients. So it's important to recognize that while we don't have all of the answers at this time, and there's still some differing opinions about certain definitions within this space, we do know enough to help our patients who are currently suffering with these issues. But I find it very important to understand how they enter our care. So by the time an individual has reached speech pathology for their cognitive issues, they've usually experienced significant challenges in navigating through the healthcare system, whether that is to finally get to a long COVID care clinic or to get the right referrals for their various symptoms. Most of them are feeling a high level of stigma, that they're not believed by their healthcare providers or even their family and friends. And so by this point in 2025, most individuals have had COVID. And so I had a patient explain, everyone in my family got COVID. I wasn't even the sickest one at that time, but now I'm the only one with these cognitive or memory issues, and my family simply can't relate or understand what I'm going through. So a high level of distress, feeling overwhelmed, and a lot of our patients uh, have a very persistent, almost rumination in comparing their current function to their pre-COVID status. And this further elevates the distress. And we hear from many, many patients that overall feeling of lack of control over both the physical symptoms and their cognitive abilities. And what I found really helpful in working with this population are various publications. I've put two of them here that describe long COVID and cognitive impairment in the context of a biopsychosocial or biopsychosocial experiential model. One by Sanders and group was published in the Lancet Respiratory Medicine journal on the left, and then I've got one from Sachs Zimmerman and group from the Archives of Physical Medicine and Rehabilitation. And while these two have some slight differences, their essence is the same. It really speaks to the dynamic, multifactorial influences on long COVID symptoms, including cognition. And so for biological things we've talked about today, like fatigue, pain, headache, anxiety, depression, PTSD, and even one that's not mentioned in the papers I'm citing, but was mentioned earlier today in the discussion of SIBO and as a contributor to brain fog. So again, many biological factors, and then psychosocially, some of the things that we have discussed in terms of loss of roles, whether that be at work or within the family unit, isolation, stigma, and for many patients, fear of contracting COVID again, which has kept some of them away from seeking rehabilitation care. And so using those models and thinking about just cognitive impairment, that would start with a cognitive evaluation. I'm a speech pathologist, and so I'm speaking to this from that perspective. But in many settings, including at Stanford, our neuropsychologists play a role, as well as our occupational therapists in the treatment of cognition. And I believe the most important step is the patient interview. And this is our time to really hear in a patient's own words their subjective reports of their current cognitive functioning and areas of deficits. And so, as Dr. Presswood put those quotes in his presentation, I think that it's very telling, right, to hear a patient's description. And it's also a time that I use to dig a little deeper on the other topics of their sleep, fatigue issues, whether or not they are experiencing some of the symptoms of mental health, and making sure that those are being addressed by other healthcare providers. It's a critical time to establish trust, respect, and validation. So this is written up a lot in the cognitive rehabilitation literature as very important for that process to be beneficial for patients. And this is where providers really need to provide that consistent messaging. There's also a lot written about in our literature about the use of appropriate language. So putting this out as something that necessarily is not permanent or extremely chronic, but this is something that can get better, that we are here to help them with their path forward out of their brain fog and cognitive impairment. Our evaluations typically include patient-reported outcome measures, which there's many of them that are published and available prior to COVID, but a way to indicate a patient's perception of what cognitive challenges they're experiencing and the impact on their daily life activities. And then objective measures. So research has shown that many of the commonly used screening tools, such as the mini mental status exam or the MOCA, may not reflect deficits in this population. So as speech pathologists, we have numerous formal testing batteries. Again, these tests were published long before the COVID pandemic, and I've listed a few here that we use here at Stanford and other long COVID sites have published about. But again, important to keep in mind that there usually is quite a discrepancy between the subjective reports of impairment and their actual testing scores. So many patients are testing perhaps in the average range, but might be experience a much greater subjective sense of cognitive impairment and might be functioning well below their pre-COVID baseline. And throughout the published literature, the exact impairments that we're seeing are in attention, memory, both the encoding and retrieval of information, verbal fluency or word finding difficulties, executive function impairment, and cognitive efficiency. But all in all, the studies to date have not found a consensus cognitive profile that is common across all of these individuals. So we want to do the testing to find out what specifically an individual is having difficulty with. And then another pivotal part of cognitive rehab is goal setting or treatment planning, which we want to do with the patient, keep it very patient-centered and individualized. And it's a good time to set realistic expectations while providing hope and that path forward. And this typically involves breaking larger goals down into more achievable steps. And this will require collaborative problem solving. So we're really tackling the specific concerns an individual might have with very specific daily activities or work tasks that they're having difficulties with. And for many patients, the cognitive impairment goes alongside this very crushing fatigue. And the thought of engaging in cognitive rehab can be very overwhelming. And so I let my patients know that I'm here to break this down into achievable tasks and steps that they can do and that they need to be actively engaged in working on in order to make their way forward and out of this brain fog, and really fostering self-efficiency and independence from day one. And another part of goal setting is understanding that the other factors like sleep, fatigue, depression, anxiety, pain, those will need to be actively addressed in order to get through and improve the cognitive impairment. So we don't treat in isolation. They really need to have all factors addressed. And while we don't have large randomized control studies published on cognitive rehab, there are some studies published to date on long COVID and cognition. And we also draw upon the literature from other similar diseases and their response to cognitive intervention. Based on that literature available, the World Health Organization put a conditional recommendation in place for cognitive rehab and recommended the focus on education, skills training on self-management strategies, and cognitive exercises. And so when we speak about the specifics of treatment, again, education being a really key component. And I've actually gotten out some of those diagrams of that biopsychosocial model that some publications have included to really show patients how complex this situation is. It often validates a lot of what they're feeling, that all of these kind of separate conditions are all really interconnected. And by working on each one of them, it's helping the collective improvement, and particularly with cognition. For treatment, we focus on both restorative exercises and compensatory strategies. So a big one patients want and benefit from are going through specific memory strategies, helping them tap into external tools and aids, including apps to help them track different information, record notes, work on their scheduling, their pacing, many different apps available and new things being added all the time. Speech pathologists already have a strong background in attention tasks and training attention from our work with, say, post-concussion patients or mild brain injury. So we'll utilize those activities. We also have longstanding experience with word finding strategies and exercises. And then I really like to include an element of metacognition, having patients really think about the way that they think, identifying their strengths and their vulnerabilities, as well as the triggers, what kind of makes the cognitive impairments flare, if you will. And we want to then target those triggers, trying to mitigate them. We want to leverage their strengths to deal with their areas of vulnerability. And here in California, we do have community resources such as the state runs the Department of Rehabilitation, where there's a myriad of services as well as a very comprehensive website with resources for individuals with disabilities trying to re-enter the workforce, or people returning from a medical leave back into work or needing accommodations. And now they have devoted a large number of their services and their website to long COVID scenarios. And so I encourage people, even if you're outside of California, you can still hop on the website and see what's out there. And then finally, as part of cognitive rehab, really focusing on that pacing and effective energy use. And so in order to pace oneself, we really have to have a strong sense of organization, planning, and ability to prioritize tasks, which is essentially our executive function from our cognitive domains. And this is, again, an area that many patients with long COVID struggle with. So by directly targeting executive function and organization, planning, prioritization skills, that in turn can help them pace themselves better, which leads hopefully to reduced fatigue, better ability to complete tasks, and in turn contributes towards improved cognition. So it's all very interconnected, and that might involve helping patients break down tasks into smaller steps, using environmental modifications, and planning their rest breaks. And on a final note, we want to make sure, again, that our patients are addressing the other issues, sleep, anxiety, mood. We definitely need to stay in our scope of practice for speech pathology, but that said, we can still help guide patients to tools to promote relaxation and wellness. Specifically, diaphragmatic breathing can be really helpful as patients experience stress response when they're experiencing a word finding difficulty, or in the moment having some cognitive difficulty. And then ensuring that our patients are referred to psychotherapy and CBT, which Dr. Laszlo just did an excellent summary for. And just a word of caution, it's really important for our patients and other providers to understand the distinction between speech pathology and OT and neuropsychology addressing cognitive rehabilitation, which I've spoken about, versus cognitive behavioral therapy, which is the psychotherapy that Dr. Laszlo spoke about to address some of the mental health issues. And so I've included in my handout that's available online some pivotal resources that speak to all of these topics in much greater detail. We appreciate the chance to start the dialogue here today. And with that, I'm going to pass it to Heidi and Courtney in physical therapy.